All right, let's jump right in. Today, we're tackling a really high-stakes diagnostic challenge. The kind where every single second and every single clue absolutely counts. We're going to step right into the shoes of a first responder to solve a truly urgent medical puzzle.
So, picture this. You're on the scene. You've got a 34-year-old woman. She's in major distress, looking you in the eye and saying she just can't breathe. Her heart is absolutely racing, her skin is pale, she's sweaty, and one reading on your monitor is basically screaming that something is going catastrophically wrong. It's her end-tidal CO2. That's just the amount of carbon dioxide in her breath when she exhales, and it's at 14. Just 14. What is jumping to the top of your list? In medicine, what we're doing right now is called forming a differential diagnosis. But really, it's just like being a detective. We've got the crime scene, which is the patient's symptoms. And now we have to line up all the most likely suspects.
Okay, so here's our lineup. We've got an anxiety attack, viral bronchitis, severe ketoacidosis, which is a really serious complication of diabetes, and a pulmonary embolism, which, is a blood clot in the lungs. Now, on the surface, any one of these could explain some of what's going on. But our job, it's to find the one suspect that explains all of it, especially those really alarming vital signs. A huge part of any investigation is just ruling stuff out, figuring out what doesn't fit the evidence. So let's start by crossing off the diagnoses that are basically red herrings in this case. So the patient definitely seems anxious, right? But here's the thing. An anxiety attack is what we call a diagnosis of exclusion. That means you only land on it after you've ruled out everything else that could actually kill them. And in this case, the hard data, the objective numbers, they're pointing to something much, much more severe. Her end-tidal CO2 of 14 is just profoundly low. That points to a serious physiological problem, not just hyperventilating from a panic attack, which would probably just give you a low to normal reading.
All right, next suspect, viral bronchitis. Well, the timeline here just doesn't fit at all. Bronchitis usually sneaks up on you over a few days, and it almost always comes with a productive cough. Our patient's crisis was sudden, acute, and there's no mention of a cough anywhere. So, nope, this is not a match.
And what about severe ketoacidosis? Well, again, the onset is the biggest clue. This is a metabolic crisis that builds up over hours, sometimes even days. And even more importantly, it causes major dehydration, which leads to warm, dry skin. Our patient, she's pale and diaphoretic, sweaty. The physical evidence just flat out contradicts this diagnosis.
So, we've ruled out 3 of our 4 suspects. You know what they say? Once you eliminate the impossible, whatever is left, no matter how improbable it seems, has to be the truth. So, let's see how all of these puzzle pieces snap perfectly into place for one single diagnosis.
When you look at the whole picture, it all points to one thing. That sudden, terrifying feeling of, I can't breathe, that's your acute dyspnea. The heart just hammering away at 130 beats per minute, trying to compensate. The pale, sweaty skin that tells you the body is in shock. And that one critically low number, the end-tidal CO2. Every single one of these is a textbook sign of an acute pulmonary embolism.
It's one thing to be able to name the condition, but to really get it, we need to understand what's happening on the inside. So what exactly is going on in this patient's lungs to create such a dramatic and life-threatening situation?
Well, it's this devastating chain reaction. First, a blood clot travels up to the lungs and basically acts like a dam, completely blocking blood flow. Now, the lungs are still doing their job. They're pulling in air. That's the ventilation part. But all that fresh air is going to parts of the lung that have no blood supply. That's the perfusion part. This creates what's called a severe ventilation-perfusion mismatch, which is just a fancy way of saying there's a total breakdown in the lung's ability to do its job. Air comes in, but there's no blood there to pick up the oxygen or drop off the CO2. And this is the crucial part, the amount of CO2 in the air she's breathing out just plummets.
In this whole cascade of symptoms and numbers, there was one piece of data that was more than just a clue. It was the smoking gun. It was the one number that cut through all the noise and pointed directly to the problem. 14. A normal end-tidal CO2 reading should be somewhere between 35 and 45 millimeters of mercury. 14, that is a sign of a catastrophic failure in the system. It basically means there's a huge amount of dead space in the lungs. Air is moving in and out, but no business is getting done. No gas exchange is happening because no blood is flowing.
And that brings us to the single most important thing to take away from this entire case. If you remember one thing, remember this. When a patient is breathing, they're moving air, but their exhaled CO2 suddenly drops off a cliff, you have to suspect a blockage in the pulmonary arteries.
It is one of the most powerful signs you will ever see for an acute pulmonary embolism.
So this all leaves us with a final thought, right? In any crisis, whether it's medical or something else, we are just flooded with information, with noise. The real skill is learning how to spot that one piece of objective data, like that ETCO2 reading, that tells the true story. So the real question is, which clues will you choose to follow?